Hi, everybody. Welcome back to the podcast. Our guest today is Dr. Andrew Wilner, a board-certified internist, neurologist, and epilepsy specialist. In 1982, he discovered that, as they call it, Locum Tenens was the perfect solution to achieve work-life balance as a physician and a writer. I'm going to ask him in a minute what that means if you don't know. Dr. Wilner has practiced Locum Tenens in a variety of inpatient, outpatient, academic, and community settings. He's a prolific medical journalist and author of several books, including Bullets and Brains. Currently, Dr. Wilner is Associate Professor of Neurology at the University of Tennessee Health Science Center in Memphis, where he cares for patients, teaches, writes, and lives with his wife and baby boy. He's also a podcaster. He is the host of The Art of Medicine. So, Dr. Wilner, thank you for joining us today. How are you?
Mark, thanks for that nice introduction. Well, it's a pleasure to be here.
I'm excited about the conversation here today. I don't normally throw a lot of Latin at the guests. Medicine loves Latin phrases. What is locum tenens first?
So locums refers to a place, and tenens is kind of like the same root as tenacity, to hold on. So it means holding a place. And it's really just a fancy way of saying placeholder, or most people are more familiar with the term substitute. Like a substitute, we all had substitute teachers along the way because our teacher was sick or went out on maternity leave. Well, for physicians, there are times when an organization, either a clinic or a hospital, needs somebody to fill in today. And maybe for a day, maybe a week, a month, or 6 months. Maybe they've hired somebody already, but that person is finishing out another contract and has to move and get a license and get credentialed. And in the medical world, that process can really drag on. So it turns out that there's a role, and frankly, an increasing role, since there's a physician shortage, for doctors, and also some nurses will do this as well. You've heard of traveling nurses.
Right.
So to come and fill in for a specified time.
And Dr. Wilner's latest book, I should also mention, is on that topic. It's called The Locum Life, A Physician's Guide to Locum Tenens. There we go. We got the cover for those on the video. So we'll come back and talk about that later in the episode. But as we always do here, though, I'm not going to let you off the hook on the key question. I know you're ready for it. For the different things that you've done in your profession, what would you say is your favorite mistake?
Right. Well, I gave that some thought, and I was looking at your book, and I was really impressed that you really had, I think, hundreds of pretty prominent people confess what they thought their favorite mistake was. So I was chatting about it last night with my wife. It's like, well, obviously there are many mistakes to choose from. And she said, oh, obviously you should just tell him it was getting married. So I don't know if this show is the best sort of format for that discussion. But I have a more professional example.
Sure.
And it's something I haven't forgotten, even though it happened probably at least, I'd have to calculate it out, but probably about 40 years ago when I was in medical training. And in those days, we worked all day, and every third night or fourth night, you simply kept working all night long and then worked the next day. So you would routinely do 36-hour shifts. And the following day, you would work a normal day and then try and finish, by 5 or 6 o'clock. Go home and shower and sleep, and get as much sleep as you can, so that the next day was kind of your easy day. And then the next day you were going to stay up again all night. Well, current medical trainees and young physicians still work pretty rigorous hours, but that particular scenario has been eliminated. So now there's a new doctor that comes in for the nighttime. But what happened was, I worked in a very busy hospital, and we weren't just sitting waiting for things to happen. When you were up all night, you were moving and seeing patients and writing orders and doing all those things. It was very rare, actually, that where I worked, you would sleep. And then you just start rounding the next day. And one day, somebody came up to me in the morning after a long night and said, Dr. Wilner, you wrote this order for Mrs. Jones to get insulin. And well, it turned out I was working on a diabetes ward where everybody got insulin, unless there was a wrinkle to that. But basically, you could be there for a heart attack if you had diabetes. You could be there because you had a wound infection, but you had diabetes. And when you're sick and you have diabetes, sugars are harder to control. If anyone listening has diabetes, they know they got to look after their sugar. But when you get sick, even if you get the flu, it throws things out of whack. So if you're critically ill in the hospital, this becomes a big job. And consequently, we had a diabetes ward. It all made sense, with one exception, is we had a young woman who was there because of a suicide attempt. And she had injected herself with an overdose of her insulin. And so her glucose has gone very, very low. And of course, our job was to get her sugar higher, whereas the usual job is to get it lower. And we were doing that by giving her intravenous glucose. Well, and what we would do, our routine was, at 11 at night, we'd check blood sugars on everybody. And then depending on what their sugar was and what the goal was, you would write insulin orders. And I did that. And they showed me my order. They said, well, you wrote for insulin on Mrs. Jones, but she's here for an insulin overdose.
Right.
I said, well, I didn't do that. I'm smart enough to know that I shouldn't do that. That wasn't our goal. I said, I didn't do that. And I was 100% convinced that I didn't do it. And these were in the days of paper charts.
Yeah.
And we literally wrote your orders and signed them. And there was a time. And they showed me the chart. And sure enough, it was my signature. And my signature is fairly unique. It would take some practice to fake it, for somebody to sign my name that way. So the truth of the matter was that not only had I made an error, which was pretty egregious, but I didn't remember doing it.
Yeah.
So there are like two mistakes. And when I thought about it, I said, well, how could this happen? And it turned out, when I thought about it, there were a lot of reasons that it happened. The obvious one is that I was sleep deprived.
Right.
And that's why I didn't remember what happened. If you've ever, stayed up all night because you were traveling or partying, things get a little blurry. And that's not really the best way to practice medicine. So I thought about it, and there was like a whole bunch of things, some of which I thought, didn't have to happen. Sometimes you make a mistake because that's just the way it is and you have no choice. But things didn't have to kind of set me up. So should we talk about that?
Yeah, it would be great to talk about that. But I just want to dig in a little bit more into the nurse speaking up to say, hey, Dr. Wilner, did you realize? And I mean, it sounds like a situation where instead of just, if you will, blindly following the medical order, she said, wait a minute, this doesn't seem right. I should say something, right?
Oh, I should clarify. No, the patient got the order. This was only hours later when somebody figured out that this was probably not the right thing, because I think the lady's glucose had tanked again because of me. And so the mistake was made. I think that's a good point. There was no check and balance in the system. We just wrote the orders and off they went.
Yeah. So maybe let's explore that a little bit too. And thank you for sharing the story there. Well, maybe it's just to close the loop on the story. We can come back to some of these elements about human factors and speaking up when an order seems to not make sense. But I feel like maybe I should let you finish the story in terms of kind of your reaction to kind of fully coming to that realization that you had written the order, you were, even if you didn't remember it, it was undeniably yours. How did that feel? What did that lead to?
Right.
Both short
So
term and long term for you as a professional.
right. So long term, it was very impactful because as a young, studious physician and very compulsive, it was my contention that I did not make mistakes.
Mm-hmm. Mm.
And I certainly wouldn't make a mistake of that amplitude.
Right.
Everybody makes little mistakes, but I would never make a mistake like that. And I did. So
Mm-hmm.
my first response was, I didn't do that because I would never do that. That's incompatible with my self-concept.
Right.
And when I realized that it was true, I had to reevaluate. I mean, this sounds maybe arrogant, but I had to reevaluate my self-concept that indeed I was fallible.
Mm.
And that one of the kryptonite for me was staying up all night.
Yeah.
That really
Yeah.
messed me up. And I needed to know that because I was going to need to stay up all night for many, many times during my future career. So I needed to know that when I am in that situation, I need to be doubly careful.
Mm-hmm.
So that was lesson one, is that I
Yeah.
am susceptible to making a grave error, that staying up all night is a risk factor, and I need to take care of that risk factor as best I can.
Right.
And I still do that. I still make sure that if I'm going to have a big day and I've got hospital patients in the morning and clinic patients in the afternoon, and I'm writing a paper, that I have adequate sleep so that I'm working on, all 4 or 8 cylinders,
Yeah.
so that everything goes the way I want it to. So it was very humbling and pragmatic, right?
Yeah.
I mean, it led to a intentional change in the way I did things.
Yeah. And I mean, being careful, I always describe like being cognizant of the risk of a mistake is helpful, but not fully sufficient because of human factors, and nobody's superhuman in terms of being able to be fully fresh after a bad night's sleep or after no sleep. But let's talk a little bit more about the human factors there, and explain. So I've heard, and I could be wrong on some of this, that there still 24-hour shifts in residency, even if it's not 36, or has that really been kind of
Well,
curtailed or eliminated?
I'd have to go look at the fine print, but there was, I'm not the only physician who's made a mistake due to sleep
Of
deprivation.
course,
And
of course.
finally, there was the Libby Zion case in New York. I'm sure you're familiar, where somebody died because an over sort of committed resident who hadn't slept enough made a very serious error. And so now I think it's an 80-hour a week, and there are rules that it can't be too many, hours sequentially. And that does limit, at 5 o'clock, my residents go home and the night float comes. And if
Mm-hmm.
there's we're in the middle of something, the resident leaves. And,
Yeah.
that kind of goes against a lot of years of that's your patient, you
Right.
stay with that patient. But it is kind of a concession that people, have limits,
Mm-hmm.
including physicians. In the old days, physicians didn't have limits. So, but now we work in these big corporate structures. But I wanted to get at something else that you hinted at, and that is the system.
Mm-hmm.
Why wasn't there someone who looked at my order and said, "Hey, that doesn't make sense"? In other words, why wasn't there a pharmacist who was informed,
Mm.
or the nurse? Maybe, the nurse could have picked it up, but it might have been a new nurse, or maybe she was, it's the middle of the night. She's just trying to get all her work done. Dr. Wilner knows what he's doing, and she gave the order. But
Yeah.
yeah, there needed to be a formal structure to sort of weed out.
Mm-hmm.
I made a similar order when, around that time where someone told me to order goots, which I'd never ordered, GOU, instead of milliliters. And I thought it was the same thing. And it turned out it wasn't the same thing at all. And the pharmacist never picked it up. So the patient got like 10 times what they were supposed to get because of my ignorance doing something that somebody told me to do. I was sort of in the chain. And then again, nobody sort of double checking.
Mm-hmm.
So that's something where the system, and of course there are, the computer now will flag things, incompatibilities and so on. But unfortunately, those tend to be more useless than useful.
Yeah.
It's an attempt to fix this problem, but it's created a whole lot of other problems.
Yeah.
It's not a good fix. We can leave it at that.
Yeah.
And so fixing it is number one, limit the hours. Number two, there should be, a double check.
Right.
And number three is how, like, our unit was set up. That woman never should have been in our unit because she didn't need insulin in the first place. She should have been in a psych unit. But instead, because of her diagnosis of diabetes, she got thrown in with everybody else. So again, it was an attempt to simplify and be efficient by putting everybody with diabetes in the same place, but it was too crude. And it's what I'm talking about is situations setting you up for an error.
Right.
And I'm interested in general aviation. And, when you always read about one of these little Piper Cubs goes down or something, it was usually not a simple mistake, right?
Sure. There's
like
a series.
The guy, it's bad weather and he was in a hurry and he thought somebody else had checked the plane, but that person didn't do it for some reason. And, there's this whole series of things that lead to the crash. It's not just, I turned the wrong dial and I made a mistake. It's not like that.
Well, that's what James Reason and others refer to as the Swiss cheese model, that different factors have to line up or conspire against you for something to happen. When you think of all the things that might not have happened, the things that might have been caught. So, to be clear, I'm not faulting you for being fatigued in that system. There were a lot of human factors and systemic causes where I would think you probably know the phrase just culture. I would say it wouldn't have been fair and just to punish you or end your career over having made a mistake.
Well, luckily the lady did fine ultimately.
Yeah.
But it was very sobering for me to realize that I could make such a dumb error, and then analyze the factors that kind of led to it, and try and avoid them. I mean, we're all human, and that's the other thing I heard just the other day. I think it was a TV show where they said there's a Japanese saying, "Fall 7 times, get up 8."
Right.
So the first time that went by me, I said, well, that really shows that, you need to persevere, you need to restart. But, the other thing that's hidden in there is like, why did you fall 7 times in the first place? So I think that's an acknowledgement of human behavior, is that, well, if you're moving forward, you are going to fall, over and over again as you get through the world, and you just need to keep getting up. But avoiding the fall, is my point, should somehow enter into there too.
Well, I mean, I'll give you credit, and like you said, the patient recovered. The patient was okay. That's great. It was still a great learning opportunity, right? So you don't have to fall 7 times. You fall once and learn from it, instead of waiting until the 3rd or the 4th or the 5th similar fall now is, let's say, an incorrect order or an incorrect dose that does, let's say, kill somebody. We can learn. That's why I think whether it's sports decisions or other business decision making, we can't just judge the outcome. Like, sometimes a bad decision that leads to an okay outcome is still a learning opportunity.
Oh yeah, sometimes you get lucky, and there's a very famous case here in Tennessee where a nurse administered the wrong medication because it started with the same letter. And they use a special dispensing machine, and it didn't want to dispense that medicine. It knew better, but she did an override to the machine because apparently the machine doesn't dispense what you need on a regular basis. So the fact that it wasn't dispensing, it wasn't that unusual. And she gave the patient what she thought was a sedative, and it turned out to be a paralytic, and the patient did
Right.
die.
Yeah.
And that's been, she was prosecuted actually as a criminal, which is why it's made national
Right.
news.
She was convicted.
Yes,
Yeah.
as a criminal, when it was really kind of it was a dumb mistake that had major implication, ramifications in the death of the patient. But it was actually a very simple error of just substituting one drug, for another drug.
But when you look at these complicating factors, whether it's the medication cabinet giving all these alerts, the EHR, electronic health record system, giving all of these alerts, like alarm fatigue is a
Alarm
very
fatigue.
real human factor and dynamic, and that seems to at least have been a contributor. That nurse was Redonda Vaught.
And I think that's
Her
still,
name,
I don't know, I don't remember all the details, but I think it's still ongoing. And of course, the nurses, if you're a physician and you're going to get criminally prosecuted for making a human error, well, first of all, that's pretty daunting. And second of all, you're pretty unlikely to admit you made an error.
Right.
So that, the whole culture of error avoidance, and I'm sure you'll agree with me, requires admitting the error in the first place so you can figure out, how not to do it again. If people are hiding their mistakes because of fear of prosecution, well, that's totally counterproductive.
Right. I agree. I agree.
But
let's talk a little bit more about maybe some changes that you've seen, because your favorite mistake story you said was roughly 40 years ago. Is there more of a team effort or an expectation that it's okay to question a physician or a surgeon or to raise a concern as a double check? Do you encourage others to speak up if they might have been conditioned not to do so with other physicians?
Well, first of all, I'd say that culture has certainly changed. It used to be, and I trained in Europe and for 2 years, and there you would just never question, the doctor in charge. Whatever he said, it didn't matter if he said, the sky is, a polka dot. It was like, yes, sir. I mean, you just went with whatever the chief of service said. And in the U.S., it might have been that way 75 years ago, but it's certainly not that way now. People are not shy to question, to the point where many physicians are irritated that they're always being second guessed when they shouldn't be. But I would say that nobody is shy to question the doctor these days. So,
and you're saying they get annoyed because they think they shouldn't be second guessed, as opposed to they shouldn't be annoyed.
Yeah, they shouldn't be second guessed because they're right 99% of the time, and it wastes a lot of time, and it's insulting. So, and then you have to go into this long explanation why you were right. And, you got to, so all to pick up that one mistake that you might make someday. So I would say that personally, I would say that the, what do they call it? The seesaw here is sort of off on the wrong side these days, where physicians are over questions and second guessed way too often. And so there's no fear of questioning physicians, I would say, or very, very minimal these days. So it kind of slows things down. And the other thing that's happened is teams have grown. It used to be the doctor and the nurse. And now there's more doctors and more nurses and physician's assistants and pharmacists and pharmacist assistants. And so you're not working in a vacuum. So that a lot more people involved. And then, of course, the electronic medical record can be accessed by, the whole team. So a lot of people are kind of looking over each other's shoulders, which I think is generally helpful. The more people that kind of know what's going on. And of course, I always tell the residents, call the other doctor. Don't just assume he's going to read what you said. There's still a big place for one-on-one talking, for communication, because a lot of errors are communication gaps.
Right.
You order something, you thought it was done. 2 days later, you find out, I didn't see that, or I don't know, someone canceled that order, or it just never got done, and you don't know. So communication is That's a big challenge, and there's a lot of work there, because of HIPAA, right? You
Hmm.
can't share details. That's even been interpreted where a doctor can't share the details with another doctor, which
Really?
is obviously counterproductive. Well, that's wrong, but there have been
Oh, but they
scenarios
think
where
HIPAA.
people have thought that, oh,
They're-
I can't
yeah.
send your
Oh,
records over there, because we got to protect your privacy. It's like, well, I'd rather get better care than worry about personally
I,
my privacy.
I agree, and I've seen in the healthcare consulting work I've done, there are often misperceptions of what people think HIPAA says
Yes.
and what the regulations actually say. But yeah, there's a big difference between sharing information with another physician or another caregiver versus leaking it to the media. That's a huge difference.
That is a big difference, and one should not leak in
No,
personal information to the media, but one should share so that the patient gets the best of care with all of the caregivers.
yeah. Then you mentioned electronic health records. When I first started working as a consultant to healthcare in 2005, paper charts were still the norm, and there were different ways where a slip of paper could get lost. Handwriting, it's the old joke that's maybe there for a reason about physicians and their handwriting, but that was a real human factor. And it seems like electronic health records and computer systems might help prevent some errors, but it introduces other errors where somebody accidentally scrolls on the mouse wheel and it changes something in a drop down, or somebody's logged into the wrong patient chart. I mean, there are still
That happens a lot because of the
mhm,
layering of windows.
mhm,
I can't tell you how often a resident's been. I said, okay, let's look at their brain scan, and they pull up the scan. I said, that doesn't really look right, and it turns out it's the last patient that we were talking about,
mhm.
not the new one. And there's no sort of double check on the EMR to prevent it from doing that. It doesn't. It'll just give you whatever button you press. That's what it does. So there's a lot of room. I think it's a good opportunity. I want to tell you about a system fix that I'm personally
Mhm.
familiar with, uh, that was like a stroke of genius and didn't cost anything.
What's that?
So when I was in practice, I remember that um, my colleague across the hall had been treating a patient that had severe headache, and he's had a CAT scan, and the CAT scan was read as negative, and everything was fine. Until one day he was shuffling through the big paper chart and he saw that, in fact, there was an addendum to the CAT scan report because it was overread by somebody else on page 2, but that page 2 had gotten separated from page 1, which said it was normal, and the addendum said that there was a brain tumor.
Hmm.
And about 2 months had passed from the time the doctor had spoken to the patient and told them that their scan was negative, till
Hmm.
the time he was probably looking, for some other thing, and stumbled on this buried report that was the addendum that showed he had a brain tumor, which obviously changes things
Yeah.
significantly. So it turns out that this was a common problem because the addendum is at the bottom.
Yeah.
Well, somebody at the Mayo Clinic figured out, why don't we put the addendum on the top?
Hmm. Good.
Because that's really the most recent,
Hmm.
latest version. If it's a book, the ending should be at the end. But when you're a physician, usually you want to know what's the latest news, and then I'll work my way back. So instead of putting addendums at the bottom of the report, they instructed all of the people that make these reports to put the
Yeah.
addendum on the top.
Well, I mean, that's like journalism where they say don't bury the lead,
Don't
and
bury the lead.
traditional newspaper reporting or is the most important thing is in the first paragraph. And then, you kind of build supporting information. And that way, if an article has to be cut for space, you're not losing the most important
But I bet
part.
that's not universal.
Yeah.
I mean, somebody had to think about it and do it. And I know they do that at Mayo because I used to work there. But I don't think everyone does that. And
Yeah.
it's an example of a systemic change. We say, oh, we can't do that. It's going to cost too much,
Nah,
blah, blah, blah.
right.
It doesn't cost anything. It's the same typing. You just put it here instead of there.
Right.
and it could change people's lives. So I thought that was a great example
That
of
is.
that there is room for cost neutral improvement just by
Mhm.
doing things differently.
Yeah, and I would much rather see a systemic fix than a bunch of reminders to be careful. Don't miss that last page. Where you get this annoying email or memo once a month, like, hey, remember, and, like, people tune that out too. That doesn't help. So let's Dr. Wilner, our guest again today is Dr. Andrew Wilner. Let's talk about your podcast before we talk a little bit about the book, The Art of Medicine. I've heard people describe medicine as both an art and a science, right? Tell us
Yeah.
about that and about the podcast.
Right. So, I think for centuries, people have realized that when you're a physician dealing with a patient, everyone is different, right?
Mm-hmm.
They have different spiritual beliefs, different religious beliefs, different physiology, different bodies, different levels of education, different social standing. And when you're communicating about a health issue, which all of us, I would say, pretty much rises to the top of our priorities when you're in the it's like sitting with your accountant, when you're
Yeah.
with the doctor, something important is going to happen here. You need to be able to communicate with that particular patient, and that has a lot to do with the art of medicine, which is not to underestimate the importance, of course, of the science of medicine.
Right.
We have medications, we have vaccines, we have surgeries, we have new technologies. That's critical. But
Mm-hmm.
I think the interesting thing is if you go back 200 years or even 100 years, back to 5,000 years, didn't really have much. And yet physicians were still very, very important in society
Mm-hmm.
because of the art of medicine, the laying on of hands. They could make people feel better by understanding what was happening and saying the right thing. And I think the art of medicine in medical school, is kind of neglected because the
Mm-hmm.
burden of science and many, in fact, I just introduced interviewed for my podcast a retired physician named Dr. Alan Sussman, who's an endocrinologist, who just wrote a book called Saving the Art of Medicine.
Mm.
And so he sought me out because he felt he ought to
Yeah.
be on the podcast, and he was right. And
Right.
what we talked about was that, when I was a medical student, there was this much biochemistry to learn. And now there's, this much
Yeah.
biochemistry to learn. And, genomics was, Mendel and the beans. And now, you can do PhD after PhD in trying to understand what we know about, gene therapy. And so the science of medicine, has really exploded. And so if you're a medical student, what you need to learn the 4 years of school are stayed the same. There's a
Right.
lot more science. And of course, what gets lost is, the art of medicine. What is my response to the patient? Do I like this guy? Does he irritate me?
Mm.
Am I feeling bad for him? Is he wasting my time? I'm a human being, so I have these
Mm-hmm.
responses. But these
Right.
responses can be very helpful for me figuring out what's wrong with that particular patient by the way, I respond.
Mm.
And, that's really, most of that's not really taught. And then how does you see bad things a lot of sometimes the resident will introduce the patient, this unlucky 49-year-old, this unfortunate,
Mm.
52-year-old. It's like, well, it's a little redundant, right? They're already here. How
Yeah.
fortunate could they be?
Yeah.
They might be particularly unfortunate, got hit by a car, and then run over by a truck. I mean, things can keep getting worse, but our job is to help in any way that we can, given whatever we're presented with. But that takes a toll. There's
Sure.
a lot of bad stories. How do you deal with that? So I'm interested on my podcast on featuring physicians and other people involved with healthcare who are trying to find ways to understand things better, to defeat burnout, for example,
Mm-hmm.
trying to be better at what they do, often by writing books, like you've written a book, and you write a book, it's like this whole thing, right? Where you focus on a topic and you
Right.
invest a lot of time, and you neglect, a lot of other priorities in your life. Your wife will tell you, right? That,
Yeah.
how come you're doing that instead of doing this? But it's a big investment. And so I like to interview physicians who've written fiction books.
Hmm.
And I have several on the podcast, or nonfiction books, and people who have written about leadership, and then financial issues. Everybody has to deal with those. We don't learn those in medical school. And you just kind of have to pick it up sort of the hard way. But that's not really the way it ought to be. But I like to feature people who have done sort of thoughtful things above and beyond what they had to do every day. And I think it shed a little light. I've had artists and poets on about the art of medicine.
Mm.
So it's fun, and I always enjoy the interviews.
Yeah. I hope people will check that out, The Art of Medicine. And then the most recent book seems clearly targeted toward physicians who are maybe considering going, locum tenens route, or those who are doing it and trying to navigate all of that. The book is The Locum Life, a physician's guide to locum tenens. What's your pitch for, let's say, a physician listening to this about
Right.
checking out your book?
So, there's this whole industry now of people trying to help physicians who are suffering burnout, right? There's a
Hmm.
lot of problems in medicine,
Right.
systemic problems that are making physicians and other healthcare providers, particularly nurses, very unhappy
Right.
in work that they selected because they were, giving helpful people, and they feel betrayed by the system because they're miserable.
Yeah.
So, one of the sort of industries for that is finding non-clinical careers for physicians. Oh, you can work in the farm industry, you could work at NIH, you could work at CDC, you can go work at an insurance company, and those are all sort of legitimate, fine careers. But for physicians who enjoy, at least in theory, clinical medicine, I think it's a tragedy because
Hmm.
clinical medicine requires a lot of training, a lot of dedication. It's very hard to do well. And for a doctor to bail, and check insurance forms, oh yeah, you really should have this CT. No, you really don't need it. I mean, to me, that's an abomination.
Yeah.
And so what Locum Tenens offers is kind of is flexibility to
Hmm.
work as much or as little as you want without the overhead of, staffing and hospital administration and a lot of the things that I do when I'm not seeing patients. You don't have to do. All you have to do in
Hmm.
a locums assignment is show up, see your patient, write your note, and go home.
Hmm.
And you can do that 1 week a year. You can do it 52 weeks a year. You can do it as much or as little as you want. And I've talked to many locum doctors that, who have talked with me, and they say, Dr. Wilner, I was kind of burned out. Said I started doing locums and I cut back and I just do it, when I want to. And I love it. I love
No.
medicine so
Hmm.
much more now that, it's not overwhelming. It makes sense, right? I mean,
Hmm.
anything you do to excess, one cup of coffee is great, but 10, you get upset stomach.
Right.
So, I mean, it's really not rocket science. And because physicians are so dissatisfied, and because there's a physician shortage, and because the system is so kind of disjointed from what it's trying to accomplish, which is take care of patients,
Hmm.
the is an increasing shortage of physicians, which means there's an increasing opportunity for locum tenens physicians. There's approximately 50,000 physicians that work locum tenens in the
Hmm.
United States, and it's growing
Hmm.
because it's not ideal, right? You don't have continuity of care the way Marcus Welby did, and you know. But on the other hand, if you can come home from a day's work and say, "Oh, that was so much fun, and I helped so many people, and I earned the amount of money I should have earned for my effort, and I'm a happy person, and I want to go back," I think it's a great solution. So my pitch is that any physician who is burned out and thinking of leaving medicine, and as I say, unfortunately, there are many, that they
Hmm.
should look at locum tenens first
Yeah.
and cut back, try locums a little bit. And, you can do locums and something else also. It can be a bridge to another career, it can be a bridge to retirement. There's a lot of ways it can be used, but a lot of doctors never even heard of it.
Yeah.
So I think the book tells a lot of stories and gives a lot of very pragmatic advice about credentialing and licensing.
Hmm.
And every now and then somebody reaches out to me, through my website and says, "Hey, Dr. Wilner, I was thinking of doing this. What do you think?" And it's nice to be able to be helpful and save someone from a life of becoming a bureaucrat instead of a clinician.
Yeah. And to each their own. And I mean, it sounds like, for one, that's a great outcome if it helps re-spark somebody's love of medicine, if it keeps them from leaving the profession altogether. And I know people who've done this, and they can do locum tenens work in some fairly exotic locations, or
Travel, yes.
go to underserved communities. Somebody who loves being out in the middle of nowhere, or somebody who loves being in a beach community, or whatever point in between. So it seems like there's a lot of interesting options out there.
Yes, and I'll say that through my website, andrewwilner.com, if people have questions about locums, I answer them for free, because I'm always interested in helping physicians who want to stay in practice. Patients, there's a lot of patients out there that need care and can't get it. And locums can provide that. So if I can provide some, guidance in 15 minutes, I'm more than happy to do that. And I do that on a fairly regular basis.
Well, great. So again, our guest today has been Dr. Andrew Wilner. I'll make sure the show notes have links to his website, his podcast, The Art of Medicine, the books. Hope people will all come check that out. So thank you for telling your story. I appreciate your willingness to share that story, to have kind of a broader conversation about those systemic factors and, in some cases, systemic fixes. So I really appreciate you being here with us today.
Well, I think the statute of limitations had run out, so I felt safe in telling the story. But it was a pleasure being here. Thanks very much, Mark.
Yeah.